Good morning. The committee will come to order. First off, I want to welcome Undersecretary Jacobs and Undersecretary Elnahal back to discuss the VA budget. Over the last 6 months, we've not been able to get a straight answer from anybody at VA about how much money they have or how much money they are spending. The numbers keep changing. VA's leaders haven't been shy about asking for billions of extra taxpayer dollars. However, when we dig into how they came up with those numbers, we get kind of the runaround, and there's no true answer from anyone. All the estimates are wrong. Basic figures about how much they have already spent are wrong too. And large parts of the VA budget requests seem to be made up. If you ran a small business this way, you would soon be out of business. Managing a $370 billion budget this way is inexcusable. The accounting disaster is insulting to every veteran, taxpayer, and member of this committee. In September, Congress appropriated $2.88 billion because Mr. Jacobs told Congress, the veterans community, and the public that if he was short by even $1 to pay the disability compensation and education benefits on September 20th, every veteran's benefit could be delayed. He told us there was no way to know before September 20th whether that would happen, and the risk was simply too great. Mr. Jacobs, I took you at your word, and I supported and encouraged my colleagues to support the appropriation. Then in October, after repeatedly sending letters pressing for an answer, we found out no benefit shortfall ever existed. VA didn't spend any of the $2.88 billion before the end of the fiscal year. Now, I understand being conservative and ensuring the funding would be in place. However, there's a big difference between $1 versus several billion. Now VA is putting out statements claiming that no one had any idea until weeks after September 20th that there was more than enough money to pay all of the benefits. I don't believe that. Somewhere along the way, someone decided to keep telling the same story about a shortfall even though the numbers didn't support it. This committee is going to find out who decided that and why. Dr. Elnahal, the situation with your health care budget seems very similar. In July, you told us your budget was so tight you had to spend every single dollar to make it the end of the fiscal year to keep delivering health care. You told us that the community care, payroll, equipment, drug, and prosthetic costs were all exploding at once. You told us you were headed for a $12 billion shortfall in fiscal year 2025, which started October 1st. The White House requested $12 billion immediately and said veterans' health care could be denied or delayed. I asked Secretary McDonald to take another look at the books before making statements like that. It turns out that the health care budget wasn't any tighter in 2024 than any other fiscal year, and VHA carried over more than $12 billion of unspent taxpayer money into 2025. Now, it turns out the community care and payroll cost didn't rise faster than normal. Now we are being told that the health care shortfall is $6.6 billion, not 12. But the explanations are the same, and they still don't add up. So this committee is going to try once again to get answers. Congress has always found ways to prioritize VA. And as I said at the beginning of this Congress, we have always funded our veterans' health care benefits, and I am confident we always will. Let me say that one more time. We have always funded our veterans' health care benefits, and I'm confident we always will. In order to do that, though, we need to get the truth from VA from the first jump, not more spin and pressure tactics. Mr. Jacobs, Mr. Elnahal, in Chicago, They have an expression that was among gangsters for when underlings had to take the blame for their bosses. It's called wearing the jacket. And I kind of suspect you're wearing the jacket right now. The budget request gets decided in the White House, and I suspect these confusing stories about the VA's budget shortfall were cooked up by the White House as well. Weaponizing the VA budget should be off limits. Scaring veterans and their families for political gain should be off limits. I don't care if it's Republican in charge, and I don't care if it's Democrat in charge. These are the people who have fought, who have died, who have sacrificed so that we can have the freedoms that we have. They do not need to be scared to death about benefits when we know we're going to provide them. You should hold yourself to a higher standard on behalf of the men and women who have served. And when I joined this committee 10 years ago, handling the VA budget like this was unthinkable. I hope we can get back to operating the right way in the next Congress. With that, I want to yield to the ranking member Takano for his opening statements.
Well, thank you, Mr. Chairman. I've got to talk about what is currently the current rhetoric that's coming from the right about veterans being on a quote-unquote payroll and living on some kind of taxpayer-funded largesse because they're lazy or don't want to work. Now, this is some kind of sick revisionist history of the last 25 years in this country where we spent over $5 trillion on the global war on terror in the aftermath of the September 11th terrorist attacks. But we didn't just spend taxpayer dollars on this war. It involved very real human cost. It cost lives and the quality of life, and it left lasting consequences for the service members who were at the forefront of the war. Service members who were exposed to choking burn pits, cancerous chemicals, blinding sand, polluted water, and more, not to mention hostile enemy fire. Now, as a country, we face the fundamental question of what we owe these individuals who serve their country so honorably. Is it simply their paycheck and maybe a thank you? Frankly, that is how some other countries treat their veterans, but that is not how we have decided to treat our veterans in America. Now, after World War I, veterans marched on Washington to fight for their benefits. And following World War II, after strong advocacy from veterans, we started paying our debts to the greatest generation through the GI Bill. Now, what we didn't know then was how much war and its human costs would continue to change during the Cold War and in Korea and Vietnam. Radiation and Agent Orange took their toll, and not just on the service members, but on their children and families. This legacy continued in the many conflicts to follow. Vietnam and Gulf War veterans are still fighting for full recognition of what they experienced, with countless veterans in their prime learning they had rare cancers. So I ask again, what do we owe veterans in this country? A recent cowardly news piece used some derisive language about this country's, quote, veteran obsession going too far, end quote. This was meant as an insult, but it didn't land like the anonymous author thought it would. If being obsessed with veterans means caring enough to honor our debts, then I will accept the charge of being obsessed. I think it is a patriotic thing to care about veterans, and not something bad or something to be ashamed of, simply because it costs money to care. There's always room to refine budget estimates and cost analyses, and I appreciate VA's commitment to make improvements to the process so that we have greater transparency and, quite frankly, faith in their accounting. And we can surely find ways to seek greater efficiency and effectiveness in the programs we fund. However, I think it is important to understand what is at stake in this discussion about budgets and needs and whether or not spending on veterans programs is somehow frivolous. Budget numbers do not portray the true cost of keeping pace with the exploding cost of health care in this country. with the cost of growing healthcare, with the cost of the growing healthcare workforce, and with the cost of shoring up and improving infrastructure. We are kidding ourselves if we think that the bare minimum funding can deliver a 21st century VA with the staffing and infrastructure to match. And it is foolish to think that there is some private sector oasis that can do it instead. For-profit healthcare is failing in this country. Hospitals are closing in rural communities. Nurses are leaving the profession. Americans are waiting long periods of time for primary and specialty care. And we're talking about the private sector healthcare system. If there's any shining star in this, it's VA. When there is no profit incentive, when the only goal is to provide care, the result is much better, and the data supports this. But keeping this up requires investment. It is a choice to support and care for veterans, and it is a promise to pay for the cost of war. Many veterans initiatives have been left on the table this Congress, from improving VA buildings to educating healthcare providers, expanding survivor benefits, restoring GI Bill benefits lost to fraud, and many others. These things were not done because it costs money to pay for them. And there are, unfortunately, many members across the aisle, and maybe even on this committee, who balk at paying for these policies. This is also a choice, but it's not mine. I believe that to value and honor the service and sacrifice of service members means to pay what we owe. The policy proposals from the incoming administration include eliminating VA health care as we know it, and there is also discussion about means testing for disability benefits. I, to use the chairman's words, think that this should be off limits. I do not support these proposals, and I will continue to fight against them in any effort to defund or undermine VA or strip benefits from veterans. These are benefits that were earned through service. They are not a dole or a gift. I hope we can have an honest discussion about true need today, but what is it going to take to continue the good work the Biden administration has done to implement the PACT Act and ensure more and more veterans have access to VA now and in the years to come? Thank you, and I yield back, Mr. Chairman.
Thank the ranking member for his opening statement, and now I would like to introduce our witnesses from the VA. I want to welcome the Honorable Josh Jacobs and Undersecretary of Benefits, and the Honorable Shereef Elnahal, Undersecretary of Health. Now, I'm disappointed Acting CFO Edward Murray was unwilling to appear or prevented from appearing today. And finally, I do want to welcome Ms. Laura Duke, and she's the Chief Financial Officer of the Veterans Health Administration, and Ms. Lasheeco Graham, and the Chief Financial Officer of the Veterans Benefits Administration. I ask all the witnesses if they would please stand and raise their right hand. Do you solemnly swear, under penalty of perjury, that the testimony that you're about to provide is the truth, the whole truth, and nothing but the truth? Thank you. Let the record reflect, you may be seated, the record reflect that the witness is answered in the affirmative. Now I'd like to recognize Mr. Jacobs for 5 minutes for his opening remarks.
Good morning, Chairman Bost, Ranking Member Takano, and members of the committee. Thank you for the opportunity to appear before you today. As you know, VA is currently delivering more benefits to more veterans, family members, and survivors than ever before. This historic success stems from the implementation of the Sergeant First Class Heath Robinson PACT Act and our unprecedented proactive outreach to connect veterans with the benefits that they've earned. This summer, VA identified several factors that required us to reassess our FY24 mandatory funding needs, largely driven by an increase in the total number of anticipated disability compensation and pension claims. Our goal was to ensure sufficient resources would be available to carry us through the end of the year and deliver on our promise to provide veterans and survivors with their earned benefits, on time and without interruption. We were mindful that a funding shortfall of just $1 would have prevented VA from processing its September pay file, delaying monthly disability compensation, pension, and education benefit payments to the approximately 7 million veterans and survivors who rely on them. When we recognized the risk of exceeding our performance targets and jeopardizing timely payments, VA notified the committee and kept Congress apprised of developments in the subsequent months. Veterans and survivors rely on these payments, and any delay could have been devastating to them and their families. And this was a risk we were not willing to take. Slowing benefits delivery was also not an option, because we know the transformative impact these benefits have on the lives of veterans and their loved ones. Like the widow of Navy veteran John Miller, who we will call Laura, from Great Lakes, Illinois. In 2012, Laura filed for DIC after John passed away from liver cancer, a condition he developed after deployment to Southwest Asia. And because that condition was not recognized as a presumptive at the time, her claim was denied. For the last 12 years, Laura was on government assistance, facing homelessness and barely making ends meet. But in February of 2024, Laura's daughter learned of the PACT Act and encouraged her mother to file another claim. With the incredible advocacy of the Veterans Assistance Commission of Lake County, Illinois, and specifically Senior Veteran Service Officer Shane McNerney, Laura's claim was granted in just 4 weeks. Once on the brink of homelessness and relying on food stamps, Laura now stands on solid ground. She was retroactively awarded back pay, no longer requires food stamps, and now benefits from a state property tax exemption, all providing her with the stability and support that she needs. This is the power of the PACT Act, life-changing support for veterans and their families. And Laura and John's story is just one of millions that demonstrates the impact of this historic law that you helped make possible. Since the PACT Act was signed into law, VA has approved more than 1.3 million PACT Act-related claims, equating to over $8 billion for veterans and survivors. In fiscal year 24, VA delivered an all-time record $187 billion in benefits to nearly 7 million veterans and survivors. And VA also processed more than 2.5 million disability benefit claims, a 27% increase over the previous year's all-time record. And thanks to the largest, most aggressive outreach campaign in VA history, veterans, family members, and survivors are applying for and receiving a variety of benefits at higher numbers than ever before. We are grateful to Congress for providing the supplemental funding that we requested. And while those funds were not immediately used, prudent management compelled VA to request that funding so veteran benefits payments could continue without interruption. In October, the amount of supplemental funding and much more was used, directly providing disability compensation, pension, and education benefits for veterans, families, and survivors. Moving forward, we are incorporating lessons learned to adjust our budget projections, including estimates for the 2026 President's budget, so we can avoid this situation in the future. That means accounting for the capacity of our workforce to deliver at record levels, anticipating higher rates of annual growth in the average disability ratings for veterans, and continuing to transparently share our status of funds reports every month. We will provide updated estimates when they're finalized and will continue providing monthly updates to this committee. We remain focused on delivering more benefits to more veterans and survivors more quickly than ever before. Thank you for your continued support of our mission and this country's veterans. I look forward to answering any questions you or other members of the committee may have.
Thank you, Mr. Jacobs. The written statement of Mr. Jacobs will be entered into the hearing record. And I would like, Dr. Elnahal, you're recognized for 5 minutes for your opening remarks.
Thank you, Mr. Chairman, Mr. Ranking Member, members of the committee, for the opportunity to testify today in support of the ongoing budget needs of the Veterans Health Administration to continue increasing services to our nation's veterans. Since the PACT Act was signed, we've broken records on care delivery to veterans. Evidence shows that VA care is often the best and most affordable option for veterans. That is why we've opened the door to VA care wider at every turn we possibly could under this law. That includes expediting eligibility for health care and launching the most aggressive outreach campaign in history to educate veterans about the resources available to them. And because of this outreach, we exceeded even the most aggressive projections for care delivered last year. At the end of FY24, nearly 800,000 veterans had enrolled in VA healthcare since enactment of the PACT Act, a nearly 37% increase over the equivalent period prior. Additionally, over 900,000 veterans saw an increase in their priority group, reducing copays and qualifying many for dental and long-term care services. We also set an all-time record for appointments delivered in fiscal year 24, all while driving down average wait times in primary care and mental health. and these trends have continued into the initial weeks of fiscal year 25. At the same time, VA care continues to outperform non-VA care in external reviews of quality. In fact, the most recent CMS overall hospital quality star ratings showed that 58% of VA medical centers scored 4 or 5 stars, compared to only about 40% of non-VA hospitals. And for 10 quarters straight, we've outperformed our counterparts in the CMS HCAP survey that measures patient satisfaction with inpatient care. Most importantly, we've increased veteran trust in VA healthcare, reaching an all-time high of 92% trust in surveys sent to every veteran after an outpatient appointment. These outcomes are the direct result of hard work from our frontline employees and leaders across the system. And through a series of access sprints earlier this year, our teams made it easier and faster for veterans to access VA care by offering night and weekend clinics, by increasing the number of veterans scheduled into daily clinics. And today, we continue to see the impact in shorter wait times for primary care and mental health. Through our referral coordination initiative, we're working to maximize the number of options we offer to every veteran, including more VA options alongside community care options should veterans qualify. And veterans have voted with their feet, often choosing VA care even when they did qualify for community care, contributing to a slower growth of referrals into the community last year than the years prior. Our clinicians have also become more productive, achieving a 9% increase in productivity per clinician since pre-pandemic levels in 2019, and a 7% increase in physician productivity specifically in fiscal year 24 alone. While we're optimizing every resource to deliver world-class care to veterans, we also face many of the same escalating costs as the private sector. In fact, the cost for drugs and medicine in FY24 increased by just over 13% compared to the approximately 9% increase that had been estimated at the time of the 2025 President's budget. And we continue to project further cost escalation. Medical inflation in drugs and prosthetics accounts for nearly half of our outstanding funding need. Because of our aggressive efforts to manage responsibly within the budget, we actually ended last fiscal year staying just under the FY24 enacted budget, an outcome we did not expect when we initially submitted our supplemental request to Congress this past July. And we managed within the budget last year despite historic growth in veteran care. This was due to strategic decisions and breaking records in care delivery, all while achieving cost savings in other areas. However, some of the cost-saving strategies we used will not be sustainable in the long run. For instance, we cannot continue to delay purchases and upgrades of certain medical equipment year over year, and we continue to believe that growth in staff rather than attrition is needed to meet increases in veteran care demand. Due to updated information about our financial position, last year we reevaluated our FY25 funding requirement and now anticipate a need of $6.6 billion, down from the $12 billion we projected in July. If VA medical care does not receive additional funding in FY25, VA will be forced to make difficult decisions to remain within the current budget. And most importantly, the next administration will start off in a position that is tough in the budget, and we don't want that to happen. We want to transition this agency responsibly to meet the needs of veterans. In summary, the most important reason we need more resources is our record in delivering more care and more benefits to veterans than ever before. Our hope is to continue this historic level of care delivery and all-time high results in quality and trust, and we believe this funding is needed to do that. I appreciate the committee's consideration, and I look forward to your questions. Thank you.
Dr. Elnahal, thank you for your statement, and the written statement of Dr. Elnahal will be entered into the hearing record. And with that, we're going to go ahead and proceed to questions. I'll recognize myself for 5 minutes. Mr. Jacobs, you said you didn't know before September 20th whether you had enough money to pay veterans benefits without the $2.88 billion. How much money did you have on September 19th?
Congressman, when we first identified the risk of a shortfall based on the updated projections, the best estimate we had at the time was the funding request that we made. We provided subsequently monthly status of fund reports showing the spend actuals versus our projections. And what we were seeing is that we were slightly under plan for the CMP account by about 0.5% and slightly over plan by about another 0.5% for the readjustment benefits accounts. We didn't have a sense of where we were when I came and testified. And historically, we know that we have a workforce that works very hard going into the end of the fiscal year, which is why we were able to achieve the $2.5 million claim a figure that we had updated back in June. So when I came here and testified, I continued to believe that we needed it. It was a conservative estimate based on a worst-case scenario. We found out after the case that, in fact, we didn't, and that was based on a number of factors. It takes us several weeks to be able to reconcile a number of those accounts, and once we were able to reconcile it, we found out that we did, in fact, not need the money.
So on September 20th, rather than saying, like you told us,
Yeah.
you were short, you just weren't absolutely sure, you really didn't know.
We had a sense that that was right for the CMP account, but we needed to take the time to do the accounting. And for the readjustment benefits, we needed, I think there were about 14 different pay files that had to go, and we had to reconcile.
Okay, when you realized that, when did you think it was necessary to come back to Congress? Didn't you think that would have been a quick move you should have done?
We wanted to verify that the accounting was correct, and so once we were able to do that in partnership with the department and OMB, and we made those notifications, we then came.
Once you realized it,
Yeah.
and you decided to tell Congress, who made that decision to say we better tell Congress?
We did that collectively. From the beginning, we have worked to be as transparent as possible to share information. That's why in July, when we identified this risk, we made the decision to notify you.
Dr. Elnahal, you revised your shortfall down to 6.6 because you actually spent much less in September than you thought. Why did you not realize this in November?
So it takes about just over a month on average to close the books and really understand exactly how much we obligated and spent in the prior fiscal year. I'm under oath, Mr. Chairman. We verified the numbers, as my colleague, Mr. Jacobs, just mentioned. And as soon as we had that verification, we ran the numbers by our colleagues in the Office of Management and OMB. We came forward with it. The timing wasn't anything other than the time that it took to verify those numbers.
So you never know in real time what money is being spent, and you don't know until months later, and that's the way the budget works?
I would say weeks later, Mr. Chairman, but I'll ask Ms. Duke in a moment to sort of describe how this works. We do not yet have a real-time financial tracking system. We have a plan to implement that would allow us to get much more fidelity on how much we're obligating on any given day and any given time. But Ms. Duke, please, thank you.
Yes, as Dr. Elnahal said, we've been engaged in a financial management business transformation for several years, a large part of which is the fact that our systems, when they gather the data from across our diverse enterprise, we have to make sure that the data coming in is accurate and that we validate it at every level. This is something our auditors have been aware of for years and have noted in our findings, and it is something that we are actively working to resolve.
Well, to both of you, I've been around here 10 years, and I believe both of you worked at VA whenever I first got here. I may be right on that. The VA's budget's been growing for a long time, and we dealt with it, and we've dealt with shortfalls. But the budget's never been this screwed up as far as what Congress sees, okay? We haven't had people come to us and ask us for large amounts of money, and oh my gosh, the sky is falling, then just to give the large amount of money, and then all of a sudden, no, we really didn't need that. You've got to understand that your credibility is shot, and that we've got to have a better system of being able told, we as members of Congress, I don't care if you're Democrat or Republican, our job is not only to pass legislation, it's also to make sure that we provide you with the money to operate this system that is vitally important to those people who need it most and that we're obligated to pay. But we can't do that unless you have competent people that actually get it right. And not coming to us, all of a sudden, we made sure before we left here on the break that we passed the 2.88. Had to do it. By golly, our veterans won't get paid. We do, and then all of a sudden we get a letter that comes back, we got almost $6 billion in that. That is a miss. I agree with the ranking member in his opening statement that, we're going to take care of our veterans. He and I agree on that. But he also, I think the idea of just handing you money with not oversight, this is the problem. We have to get this straightened out, and the only way we get it straightened out is that your agency actually gives us accurate numbers on time. We've got to have it. That oversight, because I'm going to tell you, every one of those people that you serve that have wore the uniform and the families that sacrificed, you know what? They pay taxes too. So it's a double-edged sword. With that, I'll yield to the ranking member for his questions.
Thank you, Mr. Chairman. Dr. Elnahal, just to get some sense of proportion of what we're talking about, is it correct that this supplemental funding represents about 4% of VA's overall budget?
Yes, Mr. Ranking Member, just over 4%.
Just over 4%?
Yeah.
Okay. And what's the overall budget number?
So with our supplemental request, it ends up being about $155 billion for FY25. Right now, it stands at about $149 billion.
And we're talking about $6 billion that we're talking about out of the $154 billion, okay.
Correct.
Is it correct that this supplemental funding for VHA does not anticipate much, if any, carryover in fiscal year 2026?
We do anticipate carryover, Mr. Ranking Member. I'll ask Ms. Duke to comment on how that ultimately is going to play out. There's ultimately different colors of money that inform carryover. But ultimately, the breakdown is about $3 billion between the staff we need in community care and about $3 billion in pharmaceutical and prosthetic costs and $600 million in deferred equipment costs. Ms. Duke.
Yes, sir. Just to clarify, we do not build our budget assuming carryover. We are asking for our need in 2025. We will have some carryover associated with defined use under statutory reasons like the PACT Act leases, but we are not adding into our request in the 6.6 for planned carryover into 2026.
Okay, but historically, there's been a carryover, and what on average has that carryover been?
Yeah, correct, Mr. Ranking Member. So I have data in front of me from 2019. Carryover has ranged from $6.2 billion to $12.9 billion, which represents the carryover into this year. I will say that the pandemic-related funding ultimately did distort our carryover picture and made our budget more complicated. Now, that funding was needed to save lives, and appreciated that funding. I don't want to give any sense that that wasn't appreciated, but it's ranged between 7.8% to about 9.5%, and this year it's about 9.2%.
Yeah, I remember when I asked Dr. Stone if he had asked me for enough money back when I was chairing, and he reconsidered the original amount when he grasped the gravity of the pandemic. I know my colleagues have a lot of questions about what VHA is not able to accomplish under its current budget. And we know that important projects like infrastructure improvement have been put off for years. We know that we have buildings that date back to World War II or before. But focusing on fiscal year 2025, what will happen if Congress does not address the $6.6 billion shortfall right now before we recess for the holidays? I'm concerned about these tight belt-tightening measures that cannot continue indefinitely, nor are they good for veterans' care in the long term. Would you agree?
I would, Mr. Ranking Member. The picture is essentially one where we're seeing demand continue to go up from veterans across the country. We're continuing our outreach. The bipartisan PACT Act has made the doors into our healthcare system much wider, and that's a good thing. We have evidence that says we are doing everything from reducing the risk of suicide to providing some of the highest quality care in the country. And so that is reason alone to have expanded eligibility into the system. That continues. We're enrolling more vets. Vets are relying on us more. Our reliance went from 41 to 45% this past fiscal year. We estimate that every additional percent costs about $2.6 billion. These are folks who are already enrolled, who then choose to use us for healthcare. We think all of that is a good thing, but it has costs. And so We need the money now to build capacity to be able to make sure there's a doctor, there's a clinician at the other end when all of these new veterans enroll. That's the primary reason to do this. You're mentioning infrastructure. Every 2 days on average, Mr. Ranking Member, we've had an infrastructure failure in the VA that has caused disruption in care to veterans, either the closure of a clinic or the need to move patients in a hospital. Our infrastructure situation is very serious, and we would appreciate consideration of that. By the way, it's separate from the $6.6 billion that will cover our operational needs and costs into the fiscal year, but we hope that Congress will consider major and minor construction as well.
Well, I know that I have members of my own committee who have outdated infrastructure, and I know that there are members on both sides of the aisle that need infrastructure improvements and new clinics. And anyway, my time has run out, and I appreciate your being here. Thank you for your testimony. I yield back.
Thank you, Ranking Member, and Representative Rosendale. You're recognized for 5 minutes.
Thank you very much, Mr. Chairman, for holding this hearing today. While I've not always agreed with the U.S. Department of Veterans Affairs and the Biden administration, I did largely trust that they put the veterans' interest first. I've always respected Secretary McDonough and let him know when we disagreed on policy, but I never questioned his team's desire to help veterans. Unfortunately, this whole budget shortfall has shaken my trust in VA leadership. As usual, I just call things as I see them. You guys are accustomed to that. The White House and the VA did not initially submit an accurate request for the 2025 fiscal year because I personally believe that they wanted to sneak by the spending caps established by the Fiscal Responsibility Act. The Biden administration knew if they submitted a higher VA budget request, Congress would appropriate the money. We always have. We always have. However, it would result in lower funding for agencies like the Department of Labor, the Department of Housing and Urban Development, and the Department of Justice. I know some of my Democrat colleagues think that that would be a terrible thing. I don't necessarily agree with that. But it's called budgeting. And no matter what the organization is, it has a certain amount of money to allocate. And if you spend more in one area, then you must spend less in other areas. Anybody who has run an organization recognizes that. The Biden administration prioritized funding a woke and weaponized government, and then attempted to use veterans as pawns by trying to blame Republicans if there was a shortfall to benefits or to health care. Congress provided $2.883 billion in September for disability compensation and pension and readjustment benefits as the VA requested. The VA then carried over $5.1 billion, raising concerns about whether the request was justified. Maybe Undersecretary Jacobs did need additional funding at some point, but he clearly did not need it in September. The VA also requested $12 billion for the Veterans Health Administration, but after Congress started to investigate and started pressing them on the matter, the request decreased to $6.6 billion. This budget shortfall exercise is starting to feel more like haggling and less like accounting and accurate budgeting. This only leads to more questions that the VA has been unable to answer. Now, I've said it in this committee, and I've said it on the floor, and I will say it again. Congress always seems to find extra money to build weapons and wage undeclared wars, but struggles to pay benefits to veterans that are the result of these conflicts. That doesn't, however, exempt or justify the VA not having clear and accurate budget information. Mr. Jacobs, you didn't answer the question the chairman asked. It shouldn't be a very hard question. How much compensation and pension funding did you have on September the 19th?
Let me ask Ms. Graham to provide that number.
Ms. Graham.
What we had available was the information that we had available to us at that time still begged to prove.
Just a number, Ms. Graham. If you could just give us a number.
I don't have that exact number, sir. I'll have to get that for you.
Congressman, the challenge for us is
I think you're demonstrating exactly the problem that we are all trying to identify here. Mr. Jacobs, you didn't answer the question. Ms. Graham, you won't answer the question. These are really basic accounting principles and questions.
Congressman, the issue here is when we identified the risk in June and July, we had a decision to make. because if we go even $1 over, we have to delay payments. We can't certify.
I understand that, Mr. Jacobs. I understand that, okay? But you had X amount of dollars in the account, and as demonstrated by carryovers, the VA had literally billions of dollars of additional funds that were available in other accounts. All I'm asking, I'm not even asking for the entire VA, okay? Liquid assets that were available at the time. Your one account, what was that available? And you can't even answer that one simple question.
So the latest data that I had available to me showed us that as of August, it takes us several weeks to close the books from the previous month, we had about 0.5%, which was, it was about 0.5% under for CMP, and then about 0.5% over for the readjustment benefits counseling. So we were showing that we were slightly under plan for the CMP account and slightly over plan for the readjustment benefits account, but that wasn't sufficient. That didn't give us significant assurance that we would not over index and run the risk of exceeding the
Again,
dollars.
Mr. Jacobs, but we end up with a $6 billion carryover, okay? And it's been going on for many, many years. And there were additional funds, other funds that were available. Mr. Chairman, I see that my time has expired. I will yield back.
Thank you. Representative Pappas.
Thank you very much, Mr. Chairman, and I want to say that I share the frustrations that have been expressed today about the lack of good budgetary estimates of current expenditures and projected funding needs, and how that has created confusion in the veteran community, anxiety for the veterans that we all represent. I also want to focus on how it's impacted local VA facilities, because I've heard from my medical center in Manchester, New Hampshire about this. Speak often with their leadership. Even before the July announcement, they were concerned about their ability to meet the increasing demand for veteran health care. The shortfalls that were announced only made this situation worse. It forced the facility to proactively adapt to the anticipated shortfall while still working to meet the needs of veterans. Our Manchester VA still has not received non-recurring maintenance funding that it is expected for a specialty care addition. They were already told that staffing numbers would have to remain flat in 2025, but were forced to prioritize and evaluate hiring decisions, further constraining their ability to recruit and retain the kind of healthcare professionals that our veterans need. And I know that our facility is not alone. So Dr. Elnahal, if I could turn to you and ask about the level of communication with local VA facilities on the announcement of the funding shortfall, what kind of communication and guidance was provided. And you mentioned that cost savings, some of the measures that were undertaken won't be sustained. Could you be more specific about what you mean and what the picture looks like moving forward for these facilities?
Yes, Congressman. So we have been engaging for many months now in monthly budget reviews with VISNs, and at most of these reviews, every medical center director and their team join. And we review the funding available across the agency. We also review the execution results from the prior month. And so we've really tried to engage very diligently on all of the needs. And so I will make sure I reach out to the director at Manchester. I visited Manchester. It's a wonderful facility with great leadership and a great veteran community. And I'll definitely reach out and understand their specific needs as you're mentioning them. I will say that people like Kevin at Manchester and leaders across our system saved about $2.5 billion last fiscal year, all while still breaking records in care delivery. 127.5 million appointments delivered. Sky-high results on veteran trust, quality, and patient safety. And they did that because they are responsible stewards of the taxpayer dollar. It's not something that we necessarily anticipated them being able to achieve as of July. But partly was our guidance, mostly it was their excellent management that ultimately allowed us to stay within the FY24 budget. So saving that $2.5 billion, carrying more money into this fiscal year was helpful. However, we still need $2 billion for more staff, and we still need $1 billion to support more community care. The consequence, Congressman, of not having this money in December is that folks like the Manchester team will not be able to staff up and continue to build capacity. And we're seeing the demand curve for veteran care continue to go up. And so I appreciate your consideration of that.
Well, thank you. And maybe we can get to another issue that you raised around community care. The estimates have been all over the board throughout the last few years. This was one of the factors that was contributing to the shortfall announcement in the action that Congress was asked to take. So I'm wondering if you can give us any better projections of what the picture looks like for community care moving forward into the next fiscal year.
Yeah, we estimate that we need to be able to grow community care year over year by just under 15% this coming fiscal year. Right now, the FY25 enacted budget would only allow for a 12% increase. Bigger picture, because we maximized VA offerings for care to every veteran, because our clinicians became more productive, because we were offering more telehealth options for care, because we were giving the veteran the option, putting the veteran in the driver's seat to choose where they were going, many veterans ended up voting with their feet and choosing the VA, even when they qualified for community care. And so even though we estimated that community care growth could be as high as 16%, we actually held obligations to 14.8% community care, which is a large part of why we were able to stay within the enacted budget. So we're not denying access to community care, certainly on policy or guidance. We're simply giving veterans more VA options, and that has actually led to lower growth. And we anticipate a little bit less growth into this fiscal year, but it still needs to be higher than 12%.
So less growth, but the number you project will go higher. You indicated in your testimony that it was lower this year versus last year. Is that correct?
That's right. So 14.8% in FY24. It was 16% in 23 and 22. This is year-over-year growth. And it was almost 19% from 20 to 21.
Thank you. I yield back.
Thank you. Representative Luttrell, you're now
Thank you, Mr. Chairman. Good morning, everyone. Thank you for being here today. In your opening statements, you talked about, both of you spoke about the successes of the VA and with the PACT Act and in other spaces that the VA operates, and that's amazing. But my concern is the leadership and the budgetary asks and requests. Mr. Rosendale brought up a good point to you, Mr. Jacobs. He asked for a specific number, which you handed the football off to Ms. Graham, and Ms. Graham was could not answer that question. And then you started to answer the question with a percentage. So you threw a percentage back at us, which means there's a number in there that lives and breathes. And you both should know the number, and you shouldn't show up in front of Congress and say, I don't have that information. And then Mr. Elnahal, you passed it off to Ms. Murray over there about the record-keeping capabilities of the VA or the lack thereof. And I'm assuming for the past 10, 20, 30, 40, 50 years, you've been doing the budgeting system the exact same way, since there is obviously a lack of a digital footprint that handles that problem set. Is that correct, Ms. Murray?
There are systems, but
They don't work, obviously.
they were not built with the complexity of our current appropriation picture in mind.
So Congress has allotted money to the VA to build a system that's inappropriate for the system itself.
We are in the process of transforming into a newer system. We're
Kind of like the electronic healthcare records that does not work after the billions of dollars that we're spending on it. So my question is, since we have, and as the chairman spoke, and I'm assuming every other member and every veteran sitting on this side of the aisle, plus the ones that are over there, we want an answer of why this is happening. I don't want the BS that you have to throw out because we're sitting in a committee, because we're going to meet after this. I want to know why, because we have to answer to our veterans. And if there's any group that will clack off in a hurry and show up here to ask why this is happening, because we get beat up for what you all say, and then we try to give the answers to the problem sets that are created somehow. But the answers that we're getting in here today don't give us the ability to do that. So please, somebody tell me why this is happening.
Congressman, so let me just respond to the answer that I did not answer appropriately.
Please, that'd be great.
So, it's approximately $1 billion that we were under at the end of August. It takes us, like the VHA system, we don't have day-to-day reporting on the obligations. So we're also in the process of updating our financial.
That system can't do a projection for us before you show up, Ms. Murray? I'm sorry.
Yeah. It's okay.
If Mr. Murray was here, I'd be yelling at him. Ms. Duke, I apologize, but put that on the record somewhere. Thank you. I'm sorry. My apologies, ma'am.
No worries. So your question is about whether our system does the projections?
Yes.
The system is the accounting system that shows the status of funds on a day-to-day basis.
But you can't do an annual projection of previous years to say, hey, we're going to be plus or minus?
We have additional systems that we use for those projections.
So we didn't use it?
No, we did, and that was what informed our requests at the time that we,
The request was incorrect, obviously, because we turned out we didn't need it. Yeah? Somebody?
If I could, Congressman.
Sure.
You asked why we're here, and I'm going to give you the reasons. The first and most
I
important.
know, I got them right here in front of me.
The first and most important reason is we are enacting new policy. We've made every decision possible to accelerate eligibility for VA healthcare, and we did not know what that picture would look like. And ultimately, what we did was actually enroll more veterans than we expected, and we saw reliance on our system go up on average for every single veteran because we were doing all this outreach and trying to build trust. We made a prediction. That prediction ended up being very close to ultimately what we had to spend. The second reason is just like every other agency, I think this was the motivation behind the agreement. The Fiscal Responsibility Act had us tighter than we would have expected in FY25, meaning the fluctuation of about 3-4% on which about $6.6 billion represents just over 4%, really matters. It puts us up against the line on what the funding we have available. And so the combination of the Fiscal Responsibility Act and not knowing exactly how much we would grow and how much demand would grow is the reason we are here. Nonetheless, we do have to work on budget formulation. We have to implement this new system that gives us more real-time data. Veterans deserve that. Congress deserves better information about how our budget is going to look, and that I definitely concede.
Ms. Duke, do we have, or Mr. Elnahal, do we have a projection of when that system will be activated? And I'm running out of time, so throw it at me. I'm ready.
we will start transitioning VHA this coming fiscal year.
Okay, thank you. Mr. Chairman, I yield back.
Thank you. Representative Sheffield McCormick, you are recognized for 5 minutes.
Thank you, Mr. Chairman. Under Secretary Jacobs, my question is regarding carryover. From FY23 to FY24, you carried over $17 billion and still came dangerously close to exhausting your budget. And even with the supplemental funding, VBA's carryover from FY24 to FY25 is significantly less than its previous year. Given that, are you going to have a revised FY25 budget request number? If not, do you now fear that even if Congress fully funded VBA at the FY25 request level, it would not be enough to get you through the entire year?
Congressman, you're right. We carried over far less in our CMP and readjustment benefit accounts from 24 to 25 than we did previously. In the previous 2 years, we carried over approximately $17 billion, which was about 10 and 11% for the CMP account. That was in the 24 to 25, we carried over $4.4 billion, so that was 2.5%. The readjustment benefit account, we carried over far more. In 22 and 23, we carried over $9 billion and approximately $5.5 billion, which was 43% and 30%. For the readjustment benefits account, we carried over half a percentage, which was, or we carried over 4.5%, which was $689 million. If we hadn't received the supplemental funding, we would have been about 0.5% away from exceeding our spending cap, which would have meant that if we had served approximately 5,000 more student veterans, we would have exceeded that cap and had to delay payments. That's a long way of saying we're actively looking at our FY25 mandatory funding needs right now. We're reevaluating the total estimates based on our experience here and based on updated economic projections, and then we will come back likely in the next month once we've finalized those assessments.
And is there a target amount of carryover for the VBA, either a dollar or a percentage, that allows you to operate comfortably without fear of needing to hit the panic button?
We don't set an established target. The challenge and the fundamental structural risk that this process assumes is that we're appropriating on a mandatory account, on both of these mandatory accounts. So if we exceed either of them by even $1, we risk delaying benefit payments. Other mandatory programs have authorities to provide such sums as necessary. We do not. In previous years, the department has requested and been approved by Congress to shift funding from one account to another, and that happened as recently as 2019 when there was a shortfall in one of the accounts. But what happened here in this situation is we projected shortfalls in both accounts, and so we couldn't make that request.
Dr. Elnahal, just to reemphasize, the $6.6 billion request is the minimum that VH needed, correct?
That's what we estimate, Congresswoman, to be able to keep up with the increasing veteran demand we're seeing for VA healthcare. Yes.
So that just gets you back to even for FY25, and you would actually need more than that to conduct any sort of robust capital investments, either in infrastructure or personnel. Is that correct?
Correct, Congresswoman. None of the requested funding is major or minor construction or even non-recurring maintenance against our very old infrastructure on average.
A similar question to you as well, Mr. Jacobs. Regarding carryover funds, since I know your revised FY25 shortfall assumes no carryover in FY26, what does it mean for long-term planning, both at the policy level and the medical center level, if VHA cannot count on having a cushion ahead of FY26?
I think there are decisions that we would have to make, Congresswoman, without the $6.6 billion. My concern is that we'd be setting up the next administration to have to curtail services to veterans in a way that could potentially affect their health. That is why we took the step all the way back in July, even though the funding need didn't extend until this fiscal year, to make the request. That request ended up being too high after we saw the ultimate results of the fiscal year. But the reason that I think the next team will need this money to make these investments is because we are continuing to see veteran demand go up. It is that baseline trust that continues to go up in outpatient care and inpatient care. It is the extensive outreach that I don't want to have to say we need to start curtailing. Every single veteran we enroll into our care has a better chance of getting to better health, including getting them all the services they need to ultimately reduce the risk for suicide, which is the most significant clinical and public health issue we are facing right now.
Thank you so much. I yield back.
Thank you. Representative Crane, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you guys for showing up today. I'm going to start with you, Mr. Jacobs. Your testimony indicates that last year you didn't spend 10.1% of your disability compensation and pension funding, and the year before that, 11.7%. Doesn't that suggest that Veteran Benefit Administration is holding on to too much money or ineffective in paying benefits?
Congressman, I think you're referring to the carryover in 22 and 23 in the CMP account. What I'll say is, for the 20 years leading up to the passage of the PACT Act, our CMP account grew at an average annual rate of 8%. So there was a pretty steady growth, which enabled us to make our projections with a relative amount of confidence. In the 2 years since the PACT Act has passed, we've seen significant growth well above and beyond the 8%. So in 22 and 23, we saw 17% growth, or I'm sorry, 23 and 24, we saw 17% growth and 16%. And so it's fundamentally changed the way that we are calculating the budget, particularly a budget process that starts 2 years in advance. I will also add there are things like targeted outreach that we've done that have been quite successful. Dr. Elnahal mentioned what's happening on the healthcare side. We've done outreach targeting veterans who submit what we call an intent to file, which is a process whereby a veteran can submit a claim, they start it, they have a full year to complete it and preserve the earliest possible effective date. We identified that there was a significant percentage of veterans who were not finishing the claim in that 1 year and losing that earliest possible effective date. So we did targeted outreach to them, and we were able to increase the percentage of veterans who completed it within that first year by 11%. What that's meant is we've increased the amount of retroactive awards we've been able to pay veterans. So as a kind of a base reference, in 2021, we provided $4.2 billion in retroactive awards. In 2024, that grew to $9.59 billion. Those are the types of factors that make it hard to.
All right, next question, still for you, Mr. Jacobs. Benefits dollars are mandatory. 2 times every year, VA counts up how much money is needed to pay benefits, and Congress provides it. Any budget shortfall is due to the quality of VA's estimates, not Congress's willingness to fully fund benefits. Do you disagree or agree with that?
Congressman, I agree that Congress has been incredibly generous, not only in passing our budget, but in passing the supplemental. We have to do a better job of updating our estimates, and we will do that, particularly in light of the recent changes over the past 2 years.
On that note, Ms. Duke, you were talking about this new program that you guys are going to implement this year that Mr. Luttrell was talking about. Do you have a more accurate timeline for us of when this program will be up and running?
So it's been a phased implementation across the department. VHA is the last to do the full adoption. We will be starting with it at central office this calendar year, and then we will do a pilot to make sure that we can implement it safely at a medical center without causing any danger to the patients. But we're still working on the final outreach depending on EHRM rollout as well.
All right, my next question is for also you, Ms. Duke. You were originally planning to carry over $10 billion of unspent medical care dollars into fiscal year 2025, and you actually carried over $12.9 billion. How could you have justified any budget shortfall under either scenario?
So as the 2025 budget indicated, we had planned for that carryover to be available as a resource as part of our total fiscal requirement in 2025. The actual carryover ended up being very close to what we expected in the president's budget, but we still potentially had a need. That is why we thought that the overspending in 24 would have an impact on our financial requirements in 2025 because we had planned for that carryover.
Is that typical for you guys to plan as much as $10 billion?
I would say it's
carryover?
not typical. This was in part the adjustment from the fact that the PACT Act was enacted after we had already submitted a discretionary appropriation request that didn't know that the TEF would exist.
All right, next question. Dr. Elnahal, your $6.6 billion shortfall includes $2.6 billion to purchase equipment, including $2 billion in regular annual spending and $600 million to catch up what you deferred last year. What is the equipment and why didn't you budget for it originally?
The equipment ranges, Congressman, from everything from IV pumps to more complex and technical medical equipment needed to do surgeries, medical implants. So it's a wide variety of equipment types.
Well, those equipment types seem probably pretty standard, right?
Standard, yes.
My second part of my question was, why didn't you budget for it originally?
So we actually ended up making decisions as a system to defer upgrades in a way that thankfully did not impact patient safety, at least to the information that I have, but by definition will not be possible again this fiscal year. You can only extend the life of equipment for a certain period of time, depending on what it is. You have to stay within the manufacturing guidelines on replacement and refurbishment. We were able to delay $600 million last year that we will not be able to delay again this year.
Thank you. I yield back.
Representative Bazinski.
Thank you, Mr. Chairman, and thank you, Ranking Member Takano, for this important hearing. Dr. Elnahal and Mr. Jacobs, as my colleagues have made clear here, this budget miscalculation represents a serious failure in the VA's financial management and communication processes. When the VA declared it was running out of money, it stoked real fear among veterans and their families, including those in my district that I heard directly from. Veterans wrote into my office expressing fear about losing their benefits that they rely on. I understand there is a lot of complexity in accounting for VA's needs when the budget requests are submitted, but it is unacceptable to me that an error like this was made, and I believe it raises serious questions about how such a serious mistake could have occurred. Veteran trust in VA reached an all-time high of 80% this year, but I fear major errors like this may set us back. I want to make sure VA is taking accountability for this significant mistake. At the same time, I believe this hearing and future discussions must also focus on solutions. We need to understand why these errors happened and what actions need to be taken to ensure that they just don't happen again. Dr. Elnahal, I understand the VA says it does not anticipate certain cost pressures related to prescription drugs or prosthetic devices when it submitted its fiscal 25 budget. How has the VA accounted for this expected rise in costs going into fiscal year 25 and going forward?
Yeah, medical inflation in recent years, Congresswoman, has exceeded 20% in some of the most critical items in prosthetics and pharmaceuticals. We've also seen the introduction of new drugs for obesity that are quite expensive, the injectable obesity drugs, the GLP-1 agonists, and new drugs that are more common conditions in veterans, like metabolic dysfunction-associated steatohepatitis. So it's both the mix of drugs that are becoming more expensive with good effect on veterans' health, especially the right veterans with the right clinical indications, and general medical inflation overall, which far exceeds the consumer price index.
Dr. Elnahal, VA medical facilities across the country continue to struggle with their own projected budget shortfalls. And I'm concerned about how this can affect the facilities in my district, including one, the St. Louis VA Hospital, which is obviously just outside of mine, but serves a lot of my constituents. How is the VA accounting for these individual projected shortfalls going forward in budget requests to ensure veterans are not seeing delays in care?
Yeah, I agree with you very much, Congresswoman, that we need to solve this projected need, which is why we've come forward with this request. We tried to come as early as possible last fiscal year with the request, and thankfully, because our leaders were able to make substantial cost savings to the tune of over $2.5 billion since that request, on top of changing estimates based on how we ultimately fared in the cost per FTE and other key metrics, we've been able to reduce that request. But nonetheless, that request is needed to grow staff, activate new services. And Congresswoman, we have wanted to build that new hospital in St. Louis for many, many years. And so consideration for the major construction dollars to finally do that would be very much appreciated.
Mr. Jacobs, what internal controls do you believe failed during the budgeting and forecasting process? And what immediate steps is the VA taking to address these failures?
Congresswoman, I think we have structural challenges because our mandatory accounts are structured in a way, if we exceed them by even $1, we have to delay benefit payments because we can't certify those pay files. We're making changes. There are certain flaws that we realized after the fact. One is we did not count on our employees to deliver at the incredible rate that they did. We have to account for that increased production capacity. We also underassessed the average growth rate of the disability ratings. We had the highest growth rate this past year, from 60.8% to 63.1%. That's the average disability rating for veterans. But we also need greater insight into the split between veterans that we're granting benefits for that are new to VBA and those that are coming in for a claim for increase. There's an average cost differential of about $5,000, and we erred in our assumption of the proportionality there. I think the fundamental challenge, though, that we're facing, as I mentioned a little bit earlier, is for the past 20 years prior to the PACT Act, we had an average 8% growth in CMP obligations, and in the last 2 years, we've had 17 and 16%. And so we're gonna have to take a hard look at figuring out how much we assume we will grow moving forward.
Okay, thank you. Thank you, Mr. Chairman. I'll yield back.
Thank you, Representative Brzezinski. Representative Van Orten.
Thank you, Mr. Chairman. Ladies and gentlemen, thank you for coming. Ms. Duke, the system that you're going to start implementing, did the VA develop that?
No, it's a contract system.
But are you supervising the contract?
It's through the Office of Management because it's the financial system for the whole department.
Okay. For the electronic service record, the VA originally estimated it was going to cost $10 billion. It's going to cost over 16, so that's 60% off your budget estimate. You've got 171 sites, and only 6 of them are using this so far. So you guys have blown $10 billion, and 6 out of the 71 sites have this electronic service record, and it's my understanding that you guys blew off commercially off-the-shelf technologies to develop your own. The electronic GI Bill, you couldn't seem to make it the other day to our committee hearing, Mr. Jacobs, and this is your purview, so you're getting it now, pal. The original estimate for the electronic or GI Bill was $25 million. It's now going to cost $960 million. I'm going to say that one more time. You guys told us it was gonna cost $25 million to consolidate all of these legacy systems, and it's now gonna cost $960 million. That means you were 97% off your estimate, okay? Those are real numbers. And I'm telling you right now, Ms. Duke, if the VA has their fingers in this pie, it's not gonna work. 100% it's not gonna work. This is the testimony from the IG when I was asking about this. He says, I asked him if they are good with developing software systems. VA does not have a track record of, VA has a track record of difficulty in implementing major IT systems. They almost, without fail, take longer, they take replans, so I'd prefer just to leave it at that. So the IG was intimidated, and he was afraid to tell the truth, which is you guys cannot manage anything. And there's something else I want to point out. Okay, you guys came here previously and released a statement April 21 of 2023. You said that we're going to cut your budget, and this is what you said. There's going to be 30 million fewer veteran outpatient visits and 81,000 jobs lost across the VHA. Did that take place? Did it?
No.
It did not. Undetermined access to, you're going to undermine the access to telehealth. Did we do that?
No, we've
Did
increased.
not. Do we worsen the time for benefits? No, you just said we didn't. We increased it, right? Prevent construction on the healthcare facilities and veterans' needs. We're working on that, right? Fail to honor veterans, their memory by dumping on the cemeteries. Did that happen? No. Did we cut housing for veterans? No. Did we increase food insecurity for veterans? No. Deprive veterans of mental health, substance use, and other healthcare services? No, we're expanding them. So why is this still on your website? So there's something else I want to read to you. It's a definition of a word. The quality, capability, or power to elicit belief. You know what that's the definition of? Credibility. You know what you guys have collectively? Not that. So this is embarrassing. It's embarrassing. So if you just didn't do these incredibly incompetent things, you wouldn't be here asking for more money. You would not. And so I got to ask you, sir, when does incompetence become corruption? Mr. Jacobs?
Congressman, first, let me just say, I spent a decade working on the Hill. I value the oversight that members of this committee and this body do. I think they make us better.
Okay.
I will also say, I'm incredibly proud of what we've accomplished.
Okay, all right.
over our time.
Okay, I hear this all the time. Why is this on your website? Why are these blatant lies still on your website? Why?
I would have to talk to the
So
person.
if you guys have blown billions and billions and billions of dollars, which you have, for things that still don't work, I'm asking you, when does incompetence become corruption? Because you're getting paid, Ms. Dukes, your contractors are getting paid, everybody's getting paid, right? But you know who's not being served? The veterans. So unfortunately, the head shed of the Veterans Affairs Administration has created a self-licking ice cream cone. And it's not, you're not servicing the veterans to the level that you can, because every one of these dollars that is spent in corruption, I'm just gonna say it, is not a dollar that can be applied to the health care for veterans. And you are directly responsible for that, and nobody else is. With that, I yield back.
Representative Brownlee.
Thank you, Mr. Chairman. Dr. Elnahal, nice to see you. And I know some of us on the committee have been concerned about the extent to which increased prescription drug costs are contributing to the shortfall VHA is currently facing, particularly the extent to which these increased costs are driven by VA's coverage of GLP-1 weight loss drugs like Wegovy. So we recently held a health subcommittee oversight hearing about prosthetics for amputees. We were surprised to learn that the vast majority of amputations among veterans, about 73%, are due to complications of diabetes rather than from combat injuries. So given that Wegovy is an accepted treatment of diabetes, do you agree with the logic that using drugs like this to combat chronic disease before complications develop will ultimately deliver cost savings to VA in the long term.
Well, Congresswoman, you're right in your statistics, and we do think that the veterans who will benefit most from these new GLP-1 drugs are those veterans not only with obesity, but in particular diabetes. And so that is the most common cause of amputations in the United States more generally, and our veteran community is no different. And so we actually have a range of possible costs associated with these drugs from just under $2 billion to almost $20 billion, depending upon the exact population we say qualifies. So we're going to, of course, prioritize those veterans with diabetes who stand to have the worst outcomes. Health economists are looking at the cost benefit of the GLP-1 agonists right now, so I won't comment on that. I don't have the data in front of me. But I will say that these drugs do have substantial clinical benefit, especially for veterans with type 2 diabetes.
And do you think it could yield a cost savings to the VA if you're, looking at preventing diabetes in this case versus getting diabetes and have amputations occur?
I think the primary motivation, Congresswoman, is the health and clinical benefits to veterans on this, but in particular for veterans who have more significant and harder cases of diabetes, much more comorbidities, that certainly is possible.
And are there any other drugs that you're aware of that maybe more on the expensive side, but if used to prevent disease would ultimately save money to the VA?
Yeah, the totality of what we can do on preventative health with primary care, Congresswoman, is really important. Making sure people get their screenings, especially for mortality-reducing screenings for cancer, but also making sure that the veterans who are the most complex and have the most significant clinical conditions benefit from programs like home-based primary care, which is a substantial financial investment up front, but could prevent continuous visits to the emergency room and other really targeted and important programs, including hospital care in veterans' homes, which is something we're looking at.
Thank you. You talked about home-based care, so I wanted to move into that. The committee staff recently met with a group of VA Medical Center leaders who described some of the difficult trade-offs that they are facing in order to cope with the projected budget shortfalls. Among other things, they explained that they are limited or even cutting access to non-institutional long-term care services like home-based primary care, home health aides, and respite care, the very types of services we're trying to expand through the Elizabeth Dole bill. So we know the benefits of the Elizabeth Dole bill to, veterans can age at home, and this is where they want to be. But because of VA's budget structures, where there are separate accounts or pots of money for medical services and community care, there's almost a perverse incentive for local leaders to cut access to direct care programs like these if veterans can otherwise be cared for in the community, as it will free up dollars for other direct care needs. So it's a well-known fact that veterans and taxpayers receive far greater bang for the buck by investing in home and community-based services rather than institutional long-term care. Patients and their families are obviously happier and they receive higher quality care in those circumstances. What needs to be done so that local VA medical facilities are incentivized to make operational decisions that lead to lower costs in the long run?
I think it's a really important question, Congresswoman. The disinvestment in programs like that is exactly what we want to prevent with the $6.6 billion request. We don't want folks to divest from or delay implementation of home-based primary care because by definition, they've identified a whole population of veterans who could benefit from that. And again, the principal reason is that their health would benefit, but for the most complex patients, yes, cost savings are possible with programs like this. We also have facilities that are 60% activated, clinics in Vision 6. We had Mr. Cruz, the network director, talking to members like you over the last several weeks about clinics that he wants to activate but still can't because the staff needed to do so, include a plus up over his baseline, And right now, the budget requires that we attrit staff instead of grow it. So programs like home-based primary care, programs like, national tele-oncology and the different investments we need to make, we want to continue to make them to catch up with the ever-increasing picture of demand for veteran care.
Thank you for that, and thank you, Mr. Chairman, for indulging me. I think these are important issues we need to look in further. Thank you.
Thank you. Representative Zell.
Thank you, Mr. Chairman. In 2 years on this committee, we have spent entirely too much time on errors of this magnitude or scandals, mostly in the VA headquarters. While the VHA and the VBA have made some glittering claims of record-breaking achievements in their outreach and services, the stone-cold truth is that veterans are still being let down by a system that is supposed to honor their sacrifices, their service, and provide them with the benefits they earned. We hear it all the time in our districts. The ongoing issues surrounding the financial mismanagement are totally unacceptable. It is our duty to ensure that the benefits and care promised to those who have served are delivered with efficiency, accuracy, and transparency. Unfortunately, it's very clear that you have either been trying to pull the wool over the eyes of this committee about shortfalls and your true motives, or frankly, I wouldn't trust you to balance a household budget. Let's review the facts. You've testified to them. You reported budget problems for benefits in FY24 and healthcare in 25. To fix a shortfall in benefits funding, the VA then asked for Congress for $2.88 billion. We gave it to you, but I will point out the entire House did not even vote on it. It was passed by a voice vote during debate. We thought we would be helping veterans. However, as you've told us, actually you didn't need a single penny of it. Next, the VA asked for $12 billion to cover a predicted health care shortfall in FY25. Almost by magic, you came back with a random number, $6.6 billion. I don't know that you had a rationale. If so, our credulity is strained to accept it. Mr. Jacobs, according to your testimony, the VBA carried over 2.5% of its disability compensation and pension funding unspent this year. But if I hear you correctly, you're testifying that's low. Do I remember, and I think we've already heard, that VBA didn't spend 10.1% of its funding. The year before that, it was 11.7%. To me, this indicates black and white that VBA is either holding on to too much money or is ineffective in paying benefits, more likely both. Dr. Elnahal, you've explained that VHA's budget relies heavily on unspent carryovers, basically creating what amounts to a budgetary savings account. Why not spend those funds to eliminate shortfalls so that you don't have to tell Congress if you go over by $1, benefits are not paid? I believe you should basically commit to greater transparency with Congress. You tout that VA provides more than 131 million health care appointments, that VA reached a high of 80.4% approval this year. But let's be real, that's a cover-up for longer wait times and subpar care. By the way, 80.4% satisfaction is embarrassingly low when talking about our veterans. When you put it in that context, you're bragging about veterans feeling less than absolutely certain that you'll take care of them. Veterans should have 100% confidence. We've also heard about the PACT Act. The rush to expedite services under the PACT Act only exposed the cracks that our veterans fall through in the system. How can you expedite care when at the same time you say you're on a shoestring budget? When times are tough, you tighten your belt, not buy a new one. And I don't really want to hear anything about expanding your wingspan of care and outreach. As our witnesses put it, launching the most aggressive outreach campaign in VA history. In reality, millions of veterans are falling through the cracks, I say again. Here's the deal, folks. Many veterans still don't know how to access the care that they deserve and have earned on the battlefield. This is not the time to call for a victory lap. It means we need to see some immediate changes. Your verbal testimony today, in fact, I would say, is probably not for this committee. It's for the veterans that you think are listening, that will listen to your touting of your gold-plated resumes. I'll stop with this last point. Our witnesses before us today are celebrating hollow victories. In their testimony, they write about delivering life-changing results. All I ask is that you stop making errors of this magnitude and tolerating scandals. That's all I ask. And frankly, the Senate just put out a report that your building on Vermont Avenue has a 7% utilization rate. 172 people report to your office every day. Perhaps if you had more people working in that building, we would have less errors. With that, Mr. Chairman, I yield back.
Thank you. Representative Mervan, you are recognized for 5 minutes. Representative, Levin.
Thank you, Mr.
Levin,
Chairman.
I apologize, I'm sorry.
No apology needed, Mr. Chairman.
I had not used my list correctly. You are recognized.
Thank you, Mr. Chairman. I appreciate your hosting this hearing. I think everyone who's on this committee, we have options of what committees we want to serve on. We're here because we care very deeply about our veterans, and I think when we heard about the potential for a shortfall at VA earlier this year, we took it extremely seriously. I know I did. We did what we were asked to do. We responded to that urgent call. We passed supplemental appropriations to ensure every veteran received their benefits on time. And that's why you can add my name to those who are very concerned and frustrated about what happened here. When we heard that VA had miscalculated, that there was not the budget shortfall, I think we all were wondering how it could have been, gotten so wrong. And so I thank you, Chairman, for holding this hearing to get to the bottom of it. I want to focus first on the exact methodologies that you use at VA to calculate budget projections. Undersecretary Jacobs, and I thank you for just being so responsive to me over the years and communicative with me over the years. Does VA adjust its budget projection formulas and methodologies regularly to account for changing trends in spending? And if not, why not?
Congressman, thanks very much for that question. I'll start, and then I'll turn it over to Ms. Graham to supplement. There are a variety of factors that drive our budget projections. First and foremost, we have projections that are done by our Performance Analysis and Integrity Office that look at what they estimate to be the total number of claims we will receive, as well as the number of claims we can deliver. That is fed by certain assumptions and projections from various business lines as well. And there are economic assumptions that drive the veteran behavior. There are factors that range from the total number of employees we have, as well as the amount of overtime that we have that will impact our ability to deliver. And then factors like new legislation that open up the aperture to new benefits. What we found here is we made several mistakes in terms of indexing the amount of benefits our veterans or our employees could deliver, and not accounting for the greater growth in the average disability rating for veterans because we've been able to deliver so much. And we also realized that even though we hit the 2.5 million claims completion mark that we updated in June, a greater percentage of those claims were done for veterans receiving a claim for increase rather than new veterans, which is what we thought would ultimately happen. But let me turn it over to Ms.
Go ahead, Ms. Graham.
Sir, we look at our budget 4 times throughout the course of the year. We have an internal budget, the OMB budget, the president's budget, and a mid-session review. So during those times is when we're looking at updating the assumptions, updating the case workload projections, and things of that nature to refine our estimates for how much we're going to need within those budget cycles. We're also continuing to leverage our deliberative budget procedures, our internal controls, as well as validation of the budget with the Department of Office of Management and OMB. And with the supplemental language, we are working with the IG right now to look at lessons learned and any new processes that can be put into place that will improve our formulation processes.
How would you compare, and this is for either of you, how would you compare what you just explained with the methodologies that are used in the private sector?
I'm not sure. I mean, because the private sector, they have, I would presume that their budget is not forecasted 2 years in advance like ours is. for these mandatory accounts that we have?
I think there's a fundamental difference between the way that we formulate our budget and execute the budget and the way that the private sector does it. For us, we're looking to optimize and increase the number of veterans we're serving. And so that means when we identified this risk, we chose to say, we've got a risk. Our goal is getting more veterans into care and getting connected with benefits. And so we're going to take the most conservative worst case scenario and elevate that so we don't hit it. Excuse me.
I have just a few seconds left. My concern is, since the passage of the PACT Act, we've seen incredible increases in VA enrollment, and that's a good thing. My district alone, it's between 4,000 and 5,000 new enrollees that are getting health care that didn't have it before. That's why we passed the PACT Act. But I am concerned that unless you evolve, adapt, simplify perhaps your methodology in determining your budget projections, we're going to run into this again and again and again, and it's going to get worse before it's going to get better. And I don't want to be sitting here, and I know the chairman doesn't want to be sitting here in a year or two or three with your administration, with the new administration, and have this happen again. What confidence can you give us that it won't happen again?
Congress, excuse me.
And I'm out of time.
Okay, so what I would say is there's a fundamental structural challenge that we have. The organization is going to make improvements based on the lessons learned. We're going to increase production estimates. We're going to refine the proportion of claims that are granted that are new vets or claims for increases. But unless you tackle the largest issue, which is the lack of the authority to provide such sums as necessary, there will always be this risk. And that's what led us to make this decision. A future administration may decide to make a different decision. They may decide to say nothing and hope everything goes well, run the risk of coming back here to explain why they said nothing when we delayed payments, or they may do something different like slow down or stop delivery of payments so you don't hit that record. And that's fundamentally the system design challenge that exists today.
All right. Thank you, Mr. Chairman. Yield
Mr.
back.
Kennedy, you are recognized next.
Thank you, Chairman. Good morning. Chairman, Ranking Member Takano, thank you for putting this important meeting together here today. I want to thank our panelists for your service to our veterans, your service to our country. We are very grateful for your work on a regular basis. It's great to see you here again, Dr. Elnahal. The last time you came before this committee, we discussed the infrastructure needs at the Buffalo VA Medical Center, to which you committed to visiting. You're a man of your word. You upheld your commitment, and you were able to see firsthand the issues that we're dealing with at that facility uniquely. A crumbling hospital built in the 1940s, no air conditioning, hardly any parking, room sizes not up to code. The list goes on. And I can speak on behalf of my community back home in Western New York that your visit, and I would say even more importantly, your commitment to work with us to address the issues at the Buffalo VA sparked hope for our entire community, particularly for our veterans that are dependent on services there every day. And at the end of the day, and you saw firsthand, the Buffalo VA hospital is in desperate need of resources. And frankly, we need a new VA hospital. This is a priority for me. And most veterans in my district don't want to go to a private doctor. They want to receive their care at the VA. So wouldn't you agree, after seeing the facility, that the Buffalo VA would be a strong candidate for a new build?
I do, Congressman, and I would say the same thing for so many of our medical centers across the country, unfortunately. We've got an average age of plant that is over 60 years, that is unheard of with private sector healthcare systems. Veterans notice it, our staff notice it, and they continue to deliver excellent results that exceed the private sector on quality, patient safety, and access, despite the infrastructure, not because of it. And I think the Buffalo area veterans do deserve better infrastructure. And my visit was really one of the highlights of the last several months for me. Getting to meet the team there, getting to meet the veterans there with you, and Congressman Langworthy, really did show me what was needed there.
Thank you. On behalf of our community, we thank you. And we look forward to working with the administration on advancing a new hospital in the Buffalo-Niagara region for our veterans. They deserve it. And as far as the criteria goes, you mentioned the median age of 60 years. It meets that criteria. The infrastructure, the existing technology, the window air conditioning units, dated and obsolete carpeting on the floor of these units. You worked with us and participated in roundtables at the facilities where you heard in these gaps in assets such as medical equipment and healthcare delivery due to a lack of funding and dated infrastructure. Would you suggest that the Buffalo VA is a priority project for a new build?
I would hope to see new infrastructure at the Buffalo VA Medical Center. We have a list that I know you're aware of, Congressman. It's called our SKIP list that has the priorities that have been in place for many years in terms of facilities on the queue. There are at least 7 full VA medical centers that would be ahead of Buffalo. And to be able to get to a new medical center, we'd need appropriations for major construction that exceed $20 billion, between $20 to $25 billion. Our administration has tried to request major and minor construction money year over year, and we hope that that is considered to make sure that we meet the infrastructure needs for veteran care into the future. I'm also excited about the potential for a leasing project under PACT Act 704's authority with the University of Buffalo. We're exploring the possibility of that. That project would be smaller in scale, probably between $300 to $400 million in the form of a lease, but one that would be able to extend access to care to more veterans, and one that would afford more modern infrastructure to the veterans in your district.
Thank you. I yield back.
Mr. Murban.
Thank you, Chairman. Thank you, Ranking Member Takano. And thank you for being here today. In Indiana alone, there was a 37% increase of participants in the Honor of the PACT Act. Within my district, there were thousands of individuals, 7,100 new individuals in the state of Indiana, and 4,000 new claims. That being said, Dr. Elnahal, during the November 2024 House Appropriations Milcon hearing, you noted that VHA was still finalizing a contractor to perform an external review of the budgeting process. How is VHA weighing the contract bids, and how will contractor work with OMB and IG to review the budget forecasting process?
Yes, so Congressman, the IG is auditing the circumstances around our supplemental funding need independently, and we will learn a lot from that audit. I've participated myself, my whole team has, and I think we'll be able to move forward with a lot of their recommendations once they are finished with it. I'm doing an external review, not just on the circumstances of what happened this year, but to consult very closely with our finance professionals like Ms. Duke, our strategic office that has the actuaries that do the enrollee healthcare projection model, which is our actuarial model that predicts the healthcare workload and healthcare demand that we will see into the out years, and try to find ways to actually map it to observed expenses a little bit more closely. And so that'll be a really helpful review that's, I think, wider in scope. And we're in the process. I don't get involved personally with any contracting decision, but we will choose a competent partner to do that.
Mr. Jacobs, you had mentioned that one of the reasons there was a shortfall was because the increase, if I understood correctly, the increase of percentages of service-connected disabilities from, say, 30% to 70%. Were those unanticipated, or dive a little bit deeper on why that's a major issue?
Yep, Congressman, we've historically experienced an average growth rate of approximately 1% on a year-over-year basis.
What does that mean? 1% growth rate of what?
So the average veteran is receiving disability compensation at about 60%. What we saw, and it has grown over the years by 1% every year. What we saw this past year is the largest growth rate in VA history. So we went from 60.8% to 63.1%. And it just means we're compensating veterans. They're filing for more claims. There are more veterans coming in for a claim for increase or filing for new conditions or new veterans. And they're coming in, and the cumulative impact is that we're service connecting them for more conditions at higher rates, and so they're receiving more monthly compensation. I think that's in large part, veterans are better educated, but it's also a reflection that we've been at war for the past 20 years, and veterans are getting older and getting connected with their benefits.
Is there a direct correlation between the Honor the Pact Act and those increases in percentages?
That has certainly been a large driver.
Okay. Ms. Duke, what processes have you individually identified that would lead to the shortfall overestimation in July? And what steps have you taken to ensure that the accuracy?
Thank you for that. A big portion of it, about a little under $3 billion, was the result of the efficiencies that the medical centers took in place. So when we came forward in July, we anticipated the need of the staffing to continue to increase as opposed to level out and decrease as the budget had projected. We saw growth in pharmacy particularly, and we anticipated that community care would grow at a more rapid rate. Between July and what we actually saw in the end of the fiscal year, as Dr. Elnahal mentioned, the community care rate of growth was lower than what we thought it would be when we came forward in July. And we saw the staffing start to attrit down, and also what we were paying to be lower. And also we saw the medical centers start to make discretionary decisions about not investing in equipment and tightening their belts. As a result, we ended up carrying money into 25. Some of that carryover we need to go back and fill, like if we didn't buy equipment, we still need to buy the equipment this year. But in the case of staffing, if those staff weren't on board last year, they're still not on board. We're anticipating continuing to grow to meet the need, but until those staff come on board, until the medical centers feel empowered to go out and hire at the need that they anticipate, that's why the total need is lower than what we had expected back in July.
Ms. Duke, earlier in this conversation, you had mentioned a correlation between the new software and the electronic medical records. I was chairman of technology modernization 4 years ago. That hasn't been a very quick process. This seems to be a sense of urgency where veterans and the credibility of the VA is online. Can you explain how that is correlated? Because, of course, we want to make sure that the electronic medical records comes to fruition, but that has been delayed. Please share with me how that is correlated to the process of accounting. And you also had mentioned that the accounting practices would jeopardize veterans' lives. Please share with me how that is all tied together, because I can't connect the two.
Understood. The financial management system transformation, this is not the first time that we've attempted to upgrade our systems. It's because of the interaction with the logistics and the supplies in the medical center. That is the piece that we need to make sure that as we transition into a new financial system that informs the ability to procure the supplies and materials that they need in the medical centers, that is not put in danger. And that is partly why VHA is the last part of VA to go live on the new system, because we wanted to make sure that we had appropriate safeguards in place to protect the delivery of care at the medical centers.
I thank you very much. The supply chain issues also have been a topic of conversation for a very long time. So whatever we can do to disconnect those in order to get the financial crisis solved, I think would be beneficial to the veterans. I thank you all very much for your time here today.
Dr. Murphy.
Thank you, Mr. Chairman, and thank you guys for coming. You know, I'm trying to read through a lot of this stuff objectively. I know the PACT Act put a, as we say in the Eastern North Carolina, a big hurting on you. In that we added more people, more expense, et cetera, et cetera. I get it. I get it. I'm just interested in a few statistics. So, Dr. Elnahal, you said the growth was higher than expected, and benefits exceeded, the utilization was higher than expected. Can you flesh that out a little bit? What was your expectation, and what did it turn out to be?
Yeah, we've had a trend, Congressman, on the reliance metric, the percentage of veterans enrolled in our system who choose to actively receive their care in our system, going up by, between to 0.5% to 1.5%, right around the ballpark of 1% year over year. The PACT Act significantly increased that since passage. Now we're much closer to 45%. And we estimate that
45% of what?
45% of veterans who are enrolled use the VA care regularly.
Okay.
That's the reliance metric. And so that jump is quite significant because each percentage that increases represents about $2.6 billion historically in additional costs. So if you were to just use that metric alone, you'd multiply the 4% delta by about 2.6, and you would be right around the ballpark of $10 billion.
Sure, and I think a lot of folks are having a little problem here, having run businesses, and you look at budgets and anticipation, sometimes they're on, sometimes they're off, that all of a sudden it was a $12 billion shortfall, and then, oh, no, it's not really, it's not a $6 billion shortfall. That's a lot of zeros. That's a lot of zeros and a lot of things for people to say, all right, well, do you really know what you're doing? I want to actually have a series of questions here. It is an opt-in. I've always thought it was kind of silly that the DOD, you leave the VA, you leave the active military service, and then you're in this twilight zone, whether you get picked up by the VA or not. It should be an opt-out system. It should be you go in and you have to opt out, so you don't have to spend all this time chasing people down. But that's a little different issue. Community care. There's some folks on this committee that don't like community care. As a physician that actually supplies the care in community care, I can tell you that we form the bridge to take care of veterans where the VA cannot take care of veterans. And yes, it is more expensive because guess why? It's because it's specialty care that the VA can't pay for and can't house just because they're specialists. We have a hard enough time in the private world finding specialists these days because our medical schools are not doing their job right. And so your community care issue, and you said, I believe it was going to go up 15%, 14.5 or something, if I recall.
Yeah, we think that it needs to grow by about 15% based on what we're projecting.
What are your payments in arrears on community care? Because I will tell you, that's one thing that when I ran a practice, frustrated the living hell out of me. So we wanted to take care of veterans, but you can't do it for free.
Yeah, last year, Congressman, it was about just over $36 billion that we've spent on community care.
Well, how much is arrears? How much have you not spent? Because let me tell you guys, getting paid by community care is not easy. That's a major, major problem, and this is aside a little bit from this conversation. Now, we've talked about this before. That has to be a more friendly system. We've also talked about the absolute disaster of a medical record system that's still double down, triple down, whatever, and the Oracle folks have been talking to me, I get it, but think of all the billions that would have been saved if this was done in the right at the beginning, or even understood that it needed to be fixed previously. Ms. Duke, can you tell me a little bit real quickly, and then I want to ask one final question. Just you're talking about a new auditing system.
It's not a new auditing system. It's the financial system that accounts for just basically how much we have and how much we've spent.
Whose system is it?
I'm blanking on the name. I apologize, sir.
And when was it? You said it's supposed to go live next fiscal year. How long ago was it attempted that it was going to be put in?
So it's been a rolling transformation with different parts of the department, starting with the cemetery administration and then to benefits. And now we are moving to VHA.
And I'll end with this final thought. You guys, sadly enough, one way, have to come before this committee where you get a lot of the irate and angst of members who hear from our veterans. 1 out of 10 of my constituents are veterans, and I hear about the VA shortfalls all the time. We want to be good stewards of our money. We want to take care of those who have signed on the dotted line to serve our nation, but we cannot take the bureaucracy that is destroying the very fabric of every single institution that's happening, agency in this country. I personally would love to see Deloitte, Ernst & Young, Arthur Anderson, somebody come in externally and do a forensic audit of the VA. I would love to see that. Our IG does a great job, but having people that live in the business world to come in and look at the functions and the bureaucracies and the waste and the fraud that goes into our system is absolutely what the American people deserve.
I'll just say, Congressman, I agree with you on our budget formulation process. We need an external review, and so I've asked for that. I also just want to say, last thing, that I appreciate that you're a community care provider who sees our vets. We do depend a lot. 40% of the care that we deliver is through the community, so I appreciate it.
Again, I'll double down on that. Thank you. I'll double down on it. We need an external forensic audit on government agencies that are bloated and are not meeting expectations as far as budgetary concerns. Thank you, Mr. Chairman. I'll yield back.
Representative McGarvey.
Thank you, Mr. Chairman, and I won't belabor the point, but the accounting mistakes, errors are serious. They make you all look bad. They undermine our confidence and the American people's confidence to take care of our veterans. And so, get that right. But let's talk about what I think is the real issue here, because I don't want us to miss the forest for the trees. I've got a few yes or no questions I want you all to answer, and I'll start with Dr. Elnahal. Dr. Elnahal, are there homeless veterans in America?
Yes.
All right. Mr. Jacobs, are there homeless veterans in America?
Yes.
All right, Dr. Elnahal, are there veterans in need of specialty services who are waiting weeks or months for their appointments?
Yes, unfortunately, there are some.
Mr. Jacobs, are there veterans and survivors going without their benefits while they're awaiting to hear back on their appeals?
Yes.
Yes. All right. Mr. Jacobs, are there veterans in the United States of America living in poverty?
Yes.
All right. Are there women, Dr. Elnahal, right now, who do not have timely access to all of the services they need? Are women veterans?
We're improving upon that, but yes.
All right. Dr. Elnahal, are there veterans in the United States of America who are in need of mental health care right now who don't have timely access to it?
Absolutely.
Okay. These are our veterans. These are the people who were willing to take care of us. And we don't have what we need to take care of them. And in that sense, there is a budget shortfall. And there's always going to be a budget shortfall while we have homeless veterans, while we have veterans living in poverty, while we have veterans who don't have access to the services they have earned. That's what we need to be talking about. This conversation is important. You guys made a mistake. But we're talking about 0.1% of the federal budget, while over 1 million veterans in the United States of America are living in poverty. There are veterans all over Louisville, Kentucky right now, in the South End, the East End, the West End, who are down on their luck, who need help. They should be the focus of this hearing. This conversation, while important, is like rearranging deck chairs on the Titanic. Our veterans, the brave men and women who were willing to put on a uniform and sacrifice everything to keep us safe and free, did so. And they did so because we promised them we would take care of them for their service. That is a legal and moral promise we are failing to uphold. I yield back.
Mr. Landsman.
Thank you, Mr. Chair. Sorry. Thank you, Mr. Chair. It seems to me on this, as it relates to the hearing, there was a projected shortfall, $12 billion. I think at one point I read 15, and now it's 6. So I appreciate the fact that we're doing the hearing, because I do think it's important for the American people, for taxpayers, certainly Congress, to understand why it went from one number to another, and it's not an insignificant number. I do appreciate the responses today that get at one, just the increase in demand that because of the outreach, because of the work that you all are doing, the trust that you're building up with veterans, that more and more veterans are utilizing critical services all over the country. And as a result, the cost to care for our veterans has gone up. And keeping up with those changes has been difficult, and I appreciate the honesty. And the fact that there is going to be a new system so that you can better measure where you're going to be based on pretty significant changes in enrollment and then ultimately care, right? Because more and more people are saying, not only am I going to enroll, but I would like to come in and get help. The suicide prevention work is something that I think we all deeply care about, and so I wanted to ask you about that. It does seem to be having some impact. We're seeing fewer veterans, more veterans getting the help they need, and suicide rates going down. And I'm wondering if you can speak to the work that you all are doing and what potential cuts, if the additional resources weren't provided, the impact it would have on that in particular, if you could just speak to that.
Yeah, absolutely, Congressman. And the data frustratingly lags 2 years. So this year's suicide prevention report will reflect 2022 in terms of the total number. We count every single veteran suicide. We calculate the risk overall based on the total general population. But we won't have up-to-date data even this year. Nonetheless, I do think that this request has impact on the ability to bring veterans into the system, to deliver timely care to them. And that does have bearing on overall suicide risk. Every single veteran, especially who gets VA benefits, has a lower risk of suicide on average. And by definition, the VA accepts and tries to care for the veterans who are at highest risk because of the trauma they experienced during their service and everything associated with that that leads to veteran suicide. So the broader need to increase our staffing to handle that care for veterans and also to be able to grow community care, and the need for funding the critical medications and prosthetics that they need, all these things ultimately have bearing on that public health risk, on top of the targeted suicide prevention programming that we do that's a dedicated appropriation from Congress.
Yeah, and I don't want to lose sight of, thank you, I don't want to lose sight of the money, resources that you spend on the quality assurance piece. I mean, we've talked about this in the past, which is some of the work that we're doing is highly effective and some's not. And I do think, we owe it to our veterans and their families to spend every single dollar we can on those things that are working, not only to prevent veteran suicides, but to get them in the door, right? Because there's a lot of folks that aren't being counted because they never came. And I know that you all are committed to that quality assurance. We have a bill that would require all of these dollars to be spent on those things that work by ensuring that we're taking the best practices, because we know there are some programs and some community partners that have an enormous amount of success, and that we know that others that don't. And I'm not one to say, well, let's punish the ones that don't. Let's just get them to do the best practice work that we're seeing in other programs. And so I know that isn't a lot of money, but I wouldn't want to see that be taken away from you all. So look, I appreciate the honesty. I appreciate the fact that we're doing the hearing. I do think, again, as I said at the top of my comments, it was a big change. It's an understandable one, having talked through it, and one that you all want to get better at, but I do think it was important for us to have this conversation, so thank you. You're back.
Now I want to have another round because there's some questions I need to ask, okay? And they are not related to budget, okay? And Dr. Elnahal, it is to you. We're on a current event. Is it appropriate for VA employees to have sex with each other at work?
Absolutely not.
Is there a policy that prohibits that?
I can't identify a specific policy, but it's absolutely against our values.
I can. It's Directive 5019.02, the Harassment and Public Safety Incident Policy, okay? You can check that. So why is it that we have at least 15 Mountain Home, Tennessee VA employees who have allegedly had sex on the VA property? They've not been disciplined.
Well, first thing I'll say, Congressman, is that those actions are reprehensible, extremely inappropriate. And as you know, the same time that I found out, I had you on the phone telling you about this within 2 days. And so I just wanted to thank you for working with us on this and for working with our staff to hear them out. We also have seen every implicated person leave the VA, resign, and an investigation is underway across all of the leaders and individuals involved here, from the Office of Accountability and Whistleblower Protection and the Inspector General, who recently completed an investigation. We are doing our best to hold all involved employees accountable as appropriate after these investigations conclude, and we are doubling down on trying to change the culture at Mountain Home, especially with regard to sexual harassment. Everyone takes the white ribbon pledge when they swear into their jobs in the VA, but they have to act on it. They have to live those values. And as of this point, 98% compliance with that training is in place at Mountain Home. This is not going to be just one training. It has to be a culture that continues to be instilled, and we hope to fill the medical center director job very soon.
Is that director from that medical center who has been detailed somewhere else, are they still employed with the VA?
The associate director is still employed while the investigation is still completed. That's a due process that we have to follow.
VA recently stated in a news article, employees who are involved in any wrongdoing are no longer with the VA. Is that true? If you just said, so the director apparently was not involved, correct? Except for the fact had knowledge.
There were concerns about appropriate response upon hearing the allegations. So remember, this isn't just about not committing these horrendous acts. It's about when you hear about them as a leader, you take action to protect the involved employees. Yeah. So that was the concern there. The director, for the record, voluntarily resigned.
Okay.
There is still an official who is still undertaking an investigation to really understand what the truth is behind what happened, so that one official remains employed while that is happening.
Ranking member, do you have any follow-up?
I'm just going back to the original topic of the hearing. Dr. Elnahal, given that OMB will have new leadership next month, and that new leadership will certainly have a different philosophy on federal spending, do you anticipate significant edits to your submissions in the pass-back process that could reduce the request ultimately sent to Congress?
We worked closely with OMB on this request, Mr. Ranking Member, and so the FY25 need is set by the administration. The $6.6 billion is what we hope to get this month. Ultimately, the budget process we're talking about now is relevant for the FY26 and the advance appropriation for FY27.
Thank you. I was very following what Ms. Brownlee's line of questioning, and can you just sort of explain again this perverse incentive of the medical centers in the case of direct spending on the home care that she was talking about, how the underinvesting could actually end up preventing us from saving money?
Yeah, I think a lot of our programming, Congressman, involves critical preventative care, getting care to veterans as early as possible in the trajectory of disease, and preventing exacerbation of disease, which often causes preventable emergency room visits, preventable hospitalizations, if we're actively taking care of veterans on the front end. And so programs like home-based primary care, our robust telehealth programming, our now 24/7 tele-emergency care offerings that we're doing across the system. All of these things are primarily meant to improve health, which they do, but can be quite cost-saving. And we saw that actually in the final months of last fiscal year. Because we were able to offer all of these additional VA options, we saw community care growth ultimately come in at a lower rate than we had thought as of July.
So this tele-emergency care, emergency care is one of the big drivers of the community care increase, right? And so has this tele-emergency care has it enabled you to bring down those costs?
Substantially, Congressman. So we have seen about a 6% year-over-year increase in emergency care visits in the community. That is substantially lower than recent years, part because of our tele-emergency care programming, but really all of our programming to try to prevent the need for emergency care where possible.
So shorting your ability to be able to fund these programs would be kind of like shooting ourselves in the foot. That's what you're kind of telling us?
I think so, Congressman. I think the investments need to be made now to build capacity and maintain these programs so that we don't see worsening health outcomes, principally. That's what I'm most concerned about, but also unnecessary costs from exacerbations of disease and unneeded care if we address these needs now.
Now, when you talked about tele-oncology, is that called Closer to Me? Is that the same thing?
National Tele-Oncology is a way for us to deliver both acute and follow-up care for oncology anywhere in the country from talented oncologists. The Closer to Me actually takes our infusion teams from tertiary medical centers, brings them to clinics, and disproportionately helps rural veterans who often don't even have community care options that are accessible. They can now come to our C-Box and get that infusion rather than having to go to a community.
So actually being able to refer, like whether it's Montana or other states that may have few oncologists or not even have infusion centers in rural areas, your clinics are able to deliver cancer drugs using VA's formulary. But even with that, even so, in some parts of our country, access is even in the community is not, it doesn't exist. Is that right?
Exactly. We're often, with this program, the closest option for veterans to be able to receive needed infusions, chemotherapy, targeted therapy.
And so you need to make investments in both of these areas. Is that right?
We want to make more investments in these programs because they work. And again, the funding we're requesting will help us give latitude to medical centers to increase staff to implement programs like this.
Well, Mr. Chairman, I hope that we can look at this area that we're talking about. I realize people are upset about how the news got back and all of that, but I don't want to see ourselves shoot ourselves in the foot, especially when rural veterans' health is at stake. You know, being able to deliver cancer drugs using VA's formulary, I mean, that seems like that saves us a lot of money, but it's going to save lives that we're able to get an oncologist on the phone. Because what I learned is that you don't have to actually see an oncologist in person to be able to get the oncology consultations. And that an oncologist that's located anywhere in the VA system is going to be able to help a rural cancer patient, VA cancer patient, to me is a remarkable, efficient use of your resources. I yield back, Mr. Chairman. I'm going to have to leave.
All right, thank
you. Thanks.
Before I yield to Mr. Rosendale, real quick follow-up on my questions from a while ago. What happened to these 15 employees? Were they fired? If you don't know that, can you let me know? Because we think it's important that we have an oversight on what did.
Yeah, there's still ongoing investigations, Mr. Chairman. We will update you as soon as we have resolution of them.
Please let me know. With that, Mr. Rosendale, you've got 5 minutes.
Thank you, Mr. Chairman. Appreciate it. Going to my second round. I heard some questions earlier, and folks were talking about the prescription drugs, and I certainly, as a former insurance commissioner for the state of Montana, understand that the prescription drug costs are one of the major driving factors in healthcare increases. I mean, it's nationally, it's just a fact, which is exactly why I sent you, actually, this is a second letter, Dr. Elnahal, in regards to the prescription drugs that are being used for the weight loss drugs. Thousands of dollars per month per veteran for weight loss drugs that have so many side effects, require a lifetime of taking for any benefit, and are way more expensive than the European countries, and fail to address the root cause of veterans' metabolic dysfunction. I'm a firm believer in trying to resolve the problem instead of just trying to take a pill to cover it up. And so I've got a couple of questions I want to go over. First, Ms. Duke, your earlier $12 billion request included $1 billion for injectable weight loss and liver disease drugs. Your new $6.6 billion request includes $2 billion for these drugs. How did you come up with that number?
That is based on our pharmacy benefits program, looking at the data of the veteran population and drawing conclusions based on their comorbidities, who would most benefit from the treatment provided.
Okay, and it's I've got another question, but before I go into that, so the VA is using a pharmacy benefit manager, a PBM, to take care of your pharmaceutical?
Yeah, we have an in-house pharmacy benefits management program.
Okay, so it's in-house, so you have,
Yes.
it is part of the VA, it's not a separate entity?
Yes. part of the VA.
Okay, that's good. Ms. Duke, your budget shortfall seems to be growing for the injectable weight loss and liver disease drugs, from $1 billion to $2 billion, while it shrinks in every other area. This seems to be a permanent budgetary problem, not a one-time problem. How are you going to address it in the future years?
So we use the enrollee healthcare projection model that looks at the overall trends in spending to account for overall growth in pharmacy requirements to include these drugs if our population does continue to utilize them at greater and greater rates.
Dr. Elnahal, your head of pharmacy briefed the committee staff in October that the budget for injectable weight loss medications is between $1.2 billion and $1.5 billion. I heard you reference that earlier, to treat about 10% of the eligible veterans. It would cost about $20 billion to treat all 3 million eligible veterans. What's going to happen if more than 10% of the eligible veterans get on these medications?
It's a very good question, Congressman. You can use these drugs for anybody who is overweight. And when you take that calculation, the number of veterans who are overweight, ultimately that leads to a number much closer to $20 billion. And so ultimately what we're trying to do is get this therapy to primarily veterans with not only overweight, but type 2 diabetes. That's where the strongest evidence basis exists. And after working with our pharmacy benefits management team, we estimate we'll be able to start with the highest risk veterans to the tune of about $2 billion to fund these drugs.
So my question is, my final question actually, Mr. Chair, is what's being done to promote and educate the need for lifestyle improvements, including diet and activity? What is the VA doing so that we don't have these people just relying upon these drugs that are very expensive, again, can require a lifetime of use and have all the side effects? It's like, what are we doing?
Wellness, Congressman, is first best. We have the MOVE program, which is a structured program that gets veterans exercising, does a lot of positive reinforcement, brings veterans in to show them how to do easy exercises in the beginning and then escalation, healthy eating, healthy food. We have a whole health set of programs that help veterans achieve better and better lifestyle choices. And we think that is the primary and best way to address overweight and obesity.
I believe it as well. I mean, I know folks, look, I had a compound fracture in my leg 15 years ago. It was a mess. It was an ugly mess, and I was off of it for 7 weeks. And the first thing that obviously the medical community wants to do is make sure that you aren't suffering pain, and they want to dose you up with pain pills. But there comes a point where you have to take therapy and do something about it and recognize that it's going to be a little bit painful. And so I started using a treadmill and no pain medications whatsoever. And somehow we have to get our veterans to utilize healthy lifestyles, good diet, and start controlling their weight so that we're not spending billions of dollars on prescription drugs that, again, have all these other side effects. Mr. Chair, my time is up. I yield back. Thank you so much.
Thank you. I want to thank the witnesses for appearing here today, and so we can try to understand what really happened with the VA budget. My goal is to work with the Trump administration, next administration, and next Congress to simplify the budget and make sure it serves the needs of our veterans. The budget gimmicks have gotten out of control. It should not take 6 months to figure out how much money a government has or a government agency has. Transparency would benefit everyone. The veterans needs to know, and the veteran has the resources it needs, is spending the money appropriately. Playing shell games and transferring special accounts and undermines the confidence of both in the taxpayer and the members of Congress who have to deal with it. If you can explain it, if you have to explain it, it probably shouldn't be doing it that way. It should be pretty simple. With that, I have a couple other housekeeping things that we need to bring up. I appreciate all the members here so they can hear this. Thanks. All right. Well, there's two things. One, first, I would want to recommend to all the members to remember we have a portrait tomorrow in this room at 9:30. Staff will be reaching out to you if you're listening out there. So 9:30, we would like everybody here dressed nice, okay? Please make sure you're on time. Second is a thing that's sad, but we want to acknowledge that Bill Malson here will be leaving our staff committee at the end of this Congress. And I want to thank Bill for his decades of service to this committee. Let me tell you, he is one of the most intelligent people I've ever met in my life. He has a nose to find issues. If you do realize that he was the first one on this Hill, whether Democrat, Republican, on this side of the rotunda or the other side, that realized that there was a problem with Oracle, and aggressively realized it and brought it to the attention of members. Therefore, we have been dealing with that issue. I also thank him for his dry sense of humor, because he helps tremendously to keep things a little calmed down around here. His unmatched skill at doing his job. We wish him well in where you're going, and you will be sorely missed. And I thank you for your friendship as well as your service to this committee. Thank you. And with that, I ask unanimous consent. As soon as I find my script where I'm at. There we are. I ask unanimous consent that all members shall have 5 legislative days in which to revise and extend their remarks, including any extenuous material. Hearing no objection, so ordered. The hearing is now adjourned.